There are three big respiratory viruses that basically plague our respiratory virus season and have done so since 2020. I say since 2020 because that's when the newest member of the big three appeared, and that's COVID-19. So what I'm talking about now is COVID-19, influenza, and RSV. So I'm going to try and break down these and kind of give you the most salient points, most important things to know about these three viruses. But I think it's important to remember that they're not the only respiratory viruses and certainly not the only respiratory pathogens, that there's probably a swarm of about a dozen or so respiratory viruses and even a bacteria called mycoplasma that all have somewhat overlapping symptoms that all kind of converge around certain seasons. And that primarily is going to be in the cold temperature times in the temperate climate. So that's winter. So that's our months from like October to February in the northern hemisphere, and the opposite for the southern hemisphere. In tropical areas, they basically don't have that kind of strict seasonality. Why does this happen during cold times? People congregate indoors. We know that when you share air with people, you're more likely to share their pathogens. We know that during cold times, certain parts of your immune system, really rudimentary parts, such as, for example, the hair in your nose that keeps particles out, doesn't work as well. And sometimes viruses transmit better when it is less humid, when it's colder as well. So there's a couple different reasons why that happens. But these viruses kind of come with us year in and year out. So I think it's important to know, especially because of severe seasons that might occur. So influenza is probably the most important one to know about. And why is it so important? Because it is the one that can cause pandemics. When there are different strains of influenza that might emerge, a pandemic strain could be one of those strains. And certainly that happened in 2009 and 1968, 1957, and obviously 1918, where over probably 100 million people died. So influenza is a respiratory virus that finds its home naturally in waterfowl. And there are several strains of influenza that have made their way into humans and have become our seasonal strains. And these have been known since the time of Hippocrates. He describes influenza in his writings very clearly. So influenza spread through the air, spread through surfaces, spread through droplets that you might ingest or get in your nose, your eyes, or your mouth. And it's associated with a very abrupt onset of fevers, chills, muscle aches, and pains. Sore throat can also be present, and sometimes in children they may have GI symptoms. But that's not the end of it, because in certain individuals it can progress. It can cause pneumonia. It can predispose you to get a bacterial infection, a bacterial pneumonia, and that actually was the leading cause of death during 1918 to 1919. The other thing that influenza can do is it can sometimes affect your brain, it can affect muscle systems, it can affect your heart. So it is a multi-system virus. And we've had vaccines for it since the 1940s. Actually, Jonas Salk, along with his mentor, Thomas Francis, were the first to develop these modern influenza vaccines. And the problem with influenza vaccines stems from a problem with the influenza virus itself, that just like all other viruses, it's constantly evolving, it's constantly mutating to try and get away from some of the immunity that it has to face in the human population. So we have to update our influenza vaccines in order to match what's circulating. And because we grow these vaccines in eggs, for the most part, there are better vaccines now, but still the majority of people get egg-based vaccines, there's a long lead time needed. So they will pick, for example, in the northern hemisphere, they will pick strains in late winter, early spring for what they're going to use the next fall. And during that time, things can change. And that happened during the 2025 season, where a new strain emerged and it was too late to update the vaccine, and then there was a vaccine mismatch. So that long lead time, which could be decreased by using cell-based technologies, and we have vaccines like that, like Flublok and Flucelvax, that could be minimized. And obviously mRNA vaccines, if we do get influenza mRNA vaccines, that can decrease that lead time. But because of that, we do have this risk for mismatch. And our current flu vaccines are not the best in terms of immunogenicity. Maybe that's because they don't quite match all the time, but maybe that's because they are grown in chicken eggs and they develop mutations that don't really work as well with the human immune system. But what ends up happening is the vaccines are very good against prevention of severe disease, hospitalization, and death, and that's what matters most. But they're less good against infection. that you may still get you still may get vaccinated and you still may get influenza. But you have to remember that the flu that you get is going to be less severe. In fact, when you think about pediatric influenza deaths, the vast majority of those children who die from flu every year are not vaccinated. So it is really good at doing that. There's also a nasal vaccine that's also available that you just sprayed into your nose. That may be advantageous. You can actually just order that yourself and do it yourself. You don't need to go to a doctor or a pharmacist to do the nasal spray. We test for flu, usually doing nasal swabs. That's now something that can be done over the counter. There are home flu tests. And those flu tests distinguish between flu A and B. I didn't mention flu B. Influenza B is another strain of flu that circulates every year. It's contained in our vaccine. It traditionally been thought to cause milder symptoms, but I think on a pound-for-pound basis, you can't really make that claim. Influenza B can be quite severe as well, but influenza B doesn't have the ability to cause pandemics. Our pandemics are caused by influenza A. And for completions, there is influenza C, which really has unknown clinical significance, and influenza D, which infects cows, separate from avian influenza infecting cows, but there is influenza D, and we do see antibodies in some farm workers, so that does have the ability to infect humans. But influenza A and B are the human pathogens that we worry about the most. The other thing to know about influenza is that there are antivirals. We have intravenous antivirals and we have oral antivirals. And these antivirals can be very useful, especially in high-risk people. In low-risk people, they may shorten your symptoms, make you a little bit less contagious, but in high-risk people, they may prevent complications. So it's really important if you test positive for flu to see if you need an antiviral, which could be oseltamivir, its brand name is Tamiflu, or Xofluza, which is another one that's only a single dose. So those are important things to keep in mind, that there are antivirals. They're woefully underprescribed. But flu is going to be with us year in and year out until we develop what would be the holy grail, which would be a universal flu vaccine. A flu vaccine that doesn't need updated, that is long-lasting, that provides protection against infection and severe disease. So they've been trying to perfect the way they make influenza vaccines. This has been something that's been out of reach. Well, we are getting closer and closer, but people always say that we're getting closer and closer and we still don't have an influenza vaccine. Another last point about vaccines against influenza, if you're in the high-risk group, meaning older, you need to think about getting the enhanced flu vaccine. So there's one that has an adjuvant in it, which is another chemical that helps boost your immune response, and then there's a high-dose flu vaccines. So those are what we recommend for elderly people preferentially. They probably should also go to immunocompromised individuals, and even other people could gain from getting higher dose flu vaccines because it does provide you more protection. The other thing about flu vaccines is don't get them too early. They start to become available in late summer and August. They will wear out if you get it that early because the typical flu season peaks around February. So I usually try to get the vaccine myself and recommend it to be got before Halloween. That's usually a good way to remember it. That's influenza. So the other big two, and I'm going to go through the other big two. The next is RSV. That stands for Respiratory Syncytial Virus. And people thought of that mostly as a childhood disease, that it's the leading cause of infant hospitalization. But that's not the whole story. RSV also has a major burden in the older population and the immunocompromised population. On a pound-for-pound basis versus influenza, RSV basically contends with it in terms of hospitalizations. So it is not something to kind of think of only as a childhood disease. And RSV is a virus, just like influenza, spread the same way through the air, through droplets. It has some seasonality in the winter months, just like influenza. And the thing about RSV is that it took a very long time to develop countermeasures against it because there was a lot of tricky biology that had to be figured out regarding the vaccine. And there had been failed vaccine attempts in the 1960s, and there needed to be basic science done to understand what was known as the fusion protein or the F protein of RSV, and to make sure the antibodies generated against it were protective. That problem was solved after decades of work, and that led to basically a renaissance in RSV therapeutics, or preventatives actually to be more accurate, in terms of vaccines for high-risk individuals, and vaccines for pregnant women who then pass on the antibodies that they generate through their placenta to the newborn, and RSV monoclonal antibodies, which are synthetic antibodies that you inject into a newborn, and that protects them from infection. So RSV is something that causes very familiar symptoms: cough, fever, shortness of breath, runny nose, RSV children tend to be particularly snotty, at least in my experience. In older individuals, it can cause pneumonia. It can also lead to hospitalization in older individuals, and hospitalized individuals that are older with RSV have a very high mortality. There's not a specific antiviral we use. In very immunocompromised people, we can use an older antiviral called ribavirin, which can be sometimes toxic, but we don't do that for most people, only for people that maybe had a lung transplant, for example. But RSV is something that could be eminently controllable now if more people took advantage of the monoclonal antibodies for their children, if people took advantage of the vaccine for pregnant women. All of that would really help to decrease the burden of RSV. And it can be quite bad in a pediatric hospital with lots of RSV hospitalizations. So RSV is the other of the two that we kind of dealt with forever, influenza and RSV. COVID, I don't need to do a whole video on COVID, but a couple of highlights now after this pandemic is 6 years old. So COVID-19 is a coronavirus. Coronaviruses were known to be about 25% of common cold-causing viruses when SARS-CoV-2 emerged in late 2019. COVID was the subject of a major effort to develop countermeasures. We have more countermeasures for COVID than we do for any other respiratory viruses, and that includes home tests, antivirals, monoclonal antibodies, vaccines, and a lot of hospital protocolized care. The important things to remember about COVID is it's not going anywhere. It can't magically go back into bats. It's going to become an endemic respiratory virus, just like other coronaviruses that efficiently spread from person to person. But the thing is, it's become tamer because the population has more immunity from vaccines and prior infections, and tamer because we have antivirals like Paxlovid and Molnupiravir and Remdesivir that can decrease the impact of this virus. We have home tests so people can rapidly know their status. And when a person gets hospitalized with severe COVID, we know what to do based on all of the immune system derangements that occur. We can give certain medications like dexamethasone, which is a steroid, and more sophisticated, nuanced drugs like baricitinib, tocilizumab that can be given to minimize the chance of death. But the important thing to remember about COVID is that if you're in a high-risk group, the vaccine is going to be beneficial to you. So that high-risk group includes children under the age of 2 who have very high hospitalization rates from COVID, even if they don't have any medical conditions. Just being under 2 is high risk. Being above 65, being obese, being pregnant, having hypertension, having lung disease, having heart disease, being immunocompromised, all of those conditions still need to be thinking about getting the COVID vaccines. And there's been improvements. They've changed the strain. The vaccine is trying to meet the versions of the virus that are circulating. And since Omicron appeared a couple of Thanksgivings ago, we've been able to update the vaccine and give you better protection. And there's also even a next generation COVID vaccine that may have better immunogenicity called Next Spike. So that's something important to keep in mind. But what I think falls through the cracks sometimes is people don't remember, test yourself. And if you're in a high risk group, you may benefit from an antiviral, which will keep you out of the hospital. And if you're somebody that's really severely immunocompromised, there is a monoclonal antibody that you can get infused in you that will protect you. This is something that's really important to remember, that there's these tools, but if they sit on the shelf, you won't get the benefit from them. And that last one its brand name is called Pemgarda, which is the monoclonal antibody for immunocompromised individuals. But these 3 viruses are going to be with us basically in perpetuity, unless there's a major breakthrough in vaccine science that develops some manner of giving us sterilizing immunity. And with something like influenza, I think that's going to be very, very difficult to completely free us from influenza risk because, as I said, it naturally circulates in waterfowl, and that's going to always pose some risk. But those are the big 3 viruses. But remember, there's a lot more in every flu season or every respiratory virus season. These are going to be things that you have to contend with, but it's really important to know the tools that are out there and know to ask for them and be proactive, because we often underprescribe, we meaning physicians, often underprescribe antivirals for influenza, antivirals for COVID. So make sure you ask about that and take advantage of the home tests for COVID and flu. And maybe one day we'll get a home test for RSV as well.